So we're going to have just one lecture on the endocrine system. There's a bit of material here. I'll go over it here in the lecture, and then we'll go into some more detail when we get together later this week in class. So let's just start with kind of an overview of the endocrine system, what it is, and kind of where it's located, what composes it. So the endocrine system is not like some of the other systems, like cardiovascular, where it's contained, in heart and blood vessels, or bones, where it's just kind of the structural formation of the body. The endocrine system is kind of found everywhere. It's found in different organs. It's found inside other organ systems, but it's all one coordinated system. So we're going to call the endocrine system all of the tissues that produce and secrete hormones. And hormones are going to be a protein, and we'll talk a lot about proteins in physiology. And one type of protein is a hormone that gets secreted into the blood and travels from its place of secretion, through the blood to some distant target tissue. That's what makes it a hormone. And hormones are going to be produced then by endocrine cells. And I already said there, the hormones are proteins. What makes a protein a hormone is the fact that it's produced by an endocrine cell, gets secreted into the blood, and travels a distance to a target tissue. That's kind of the definition of a hormone. And you can see here in the picture that endocrine tissue is found pretty much everywhere in the body. We have some endocrine tissue that's found in the brain, such as the pineal gland. We talked about melatonin being produced there in class. The hypothalamus and the pituitary gland, those are both connected with the brain, and we're going to see that they're kind of the controllers of the endocrine system. Thyroid gland is located here in the neck. It overlies the trachea. The thymus gland is here in the chest, kind of in the mediastinum, if you remember that term. The heart itself produces some hormones. Your fat tissue produces hormones. There are numerous hormones produced in the digestive tract. The kidneys produce hormones. The ovaries and testicles produce hormones. The pancreas produces hormones. So you can see that they're really all over the body, and the adrenal glands, which sit on top of the kidneys, also produce hormones. So it's hard to localize the endocrine system, but it is one unified system that communicates within itself and between different parts of the body. And we're going to go through and look at how the hypothalamus and the pituitary kind of control the flow and production of hormones. And then we'll take a look at some of these specific glands, such as the pancreas and the adrenal gland and the thyroid gland, and how they make and secrete their hormones. We will meet some of the other hormones in physiology when we do those particular body systems. So for example, when we do the heart in physiology, we'll talk about atrial natriuretic peptide and brain natriuretic peptide. We'll talk about numerous hormones in the digestive tract when we get to physiology, some that are made in the kidneys. So we won't focus so much on those in this lecture, but when you get to physiology, you'll learn a bit more about those. So we just finished the nervous system, and now this is the reason I've chosen to put the endocrine system right after the nervous system, is that both of them really are a system for communication. And in fact, even though we talk about the nervous system and the endocrine system separately, there's really a bit of overlap between the two systems. Since both of them are, the primary purpose of both of them is communication, we're going to see that there's some overlap, and the distinction between nervous system and endocrine system is not quite as distinct as maybe you learned in middle school or earlier, or certainly not as distinct as I learned even in college. We're finding that there's a lot of overlap. So let's look at what is some of the distinctions between the communication that occurs through the nervous system and the communication that occurs through the endocrine system. So both are communicating between different tissues, but they're doing it in a little bit of a different way. So the nervous system we just finished, and we talked about how the nerves eventually release neurotransmitters onto its target tissue, either onto another nerve so that electric action potential gets carried from one nerve to another, or maybe the neurotransmitter is released on a muscle and it causes contraction, or maybe it's released on a gland actually and causes the production of a hormone. But either way, it causes its effect through the release of neurotransmitters. Now, what's important about the nervous system is that it's very fast. So imagine you're touching a hot stove and you need a system that can communicate heat, pain, danger very rapidly, because you want to be able to remove your hand from the dangerous fire, and you want to do that quickly. And that's why we have a nervous system. So that signal will go from the hand to the spinal cord and back out to the hand, causing a reflex withdrawal of the hand whenever you touch something hot or painful. That's very fast communication, and that occurs through the nervous system. It's also a shorter effect. Once you remove your hand from the heat, you don't keep removing your hand. You don't keep contracting your muscles. Once the danger has been removed, you're able to kind of relax. So it can be just for a second that communication lasts. It's also more specific, meaning when I reach out my right hand and I touch something hot, it's not my whole body that jumps, but rather just my right hand that withdraws. My left hand doesn't withdraw. The signal doesn't go all over the body. It's targeted to where the danger is. So it would be targeted right to my hand where the heat is. Okay, the endocrine system we're going to see has some different effects, and some of them are going to be opposite. So rather than causing an effect through neurotransmitters, they're going to cause their effect through hormones, and we already talked about what hormones are. So they're going to have a slower onset, so they're going to take longer for the signal to produce production of hormones and then secretion of hormones, and then those hormones have to go in the blood and travel to their target tissue. So all that's going to take time. So it's going to take a bit longer for that communication to occur. So we don't really want it for time-sensitive emergencies like pain, but it is useful because it has a longer effect. So whereas the nervous system kind of gets there quick and is over very quickly, the endocrine system is going to take longer to communicate, but once those hormones are in the blood, they're going to stay around a bit longer, often for several hours, even days perhaps, and they're going to cause a more generalized communication. What we'll learn in physiology is that the response to a hormone is determined by the receptor on the target tissue. So for example, let's say my thyroid gland releases thyroid hormone into the blood. Well, that thyroid hormone goes everywhere. It lands on my brain, it lands in my skin, it lands in muscle tissue, bone tissue, kidney tissue, heart tissue. It goes everywhere. But not every type of tissue responds to that thyroid hormone. Only the tissue types that have a receptor for that hormone will actually see the hormone and respond to the hormone. So the response is determined by whether or not the tissue has a receptor for that hormone. But the hormone goes out kind of in a generalized fashion. Once it gets into the blood, it's going to go everywhere. Now, there is some, as I mentioned, crossover. So, for example, the adrenal medulla, if you remember, we talked about that in the nervous system because the sympathetic autonomic nervous system is able to stimulate the adrenal medulla and cause the release of epinephrine and a little bit of norepinephrine. And that's kind of, those are the epinephrine and norepinephrine in the brain are considered neurotransmitters. But when they're released from the adrenal medulla, sitting on top of the kidneys and put into the blood supply, we don't call them neurotransmitters, we call them hormones. But they're really the same compound. It's the same protein. It's just when it occurs from a nerve, released from a nerve, we call it a neurotransmitter, and when it's released from the adrenal medulla, we call it a hormone. So you see there's kind of a murkiness or a muddiness to these two terms, endocrine system and nervous system. Sometimes there's an overlap, such as occurs with the adrenal medulla. The hypothalamus as well, the hypothalamus is part of the brain. You guys learned that. It's part of the diencephalon. But we're going to see here in the endocrine system that it's also kind of the king over all of the endocrine system, and actually itself makes two hormones. Even though it's nervous tissue, it also acts as an endocrine organ and is going to make hormones. So we see that there's a bit of overlap between the nervous system and the endocrine system. That'll become more important when we get to physiology. Okay, so the hypothalamus and the pituitary, we're going to talk about together. They form what we call an axis. We call it the hypothalamic pituitary axis. So maybe you've heard the phrase that the pituitary is the master gland. So I've always tried to figure out, if the pituitary is the master, what's above a master? And I don't really know, but I decided to say the king is above the master, or maybe you could call the hypothalamus the emperor, the supreme leader. Somehow the hypothalamus has to be put hierarchically above the pituitary gland. And if the pituitary is the master gland, then the hypothalamus is something even higher. So what we're going to see is that the signal to release many of the hormones in your body actually begins in the hypothalamus. And the hypothalamus is going to send a signal via a hormone to the pituitary gland, which is going to tell the pituitary gland to release a hormone that's going to then go to the gland, let's say the thyroid gland or the pancreas or the adrenal medulla or the ovaries or the testes, and it's going to tell those glands to produce and secrete particular hormones. So we're going to see it starts with the hypothalamus, which then directs the pituitary, and the pituitary then directs the rest of the glands. And so we're going to look at that axis, especially when we get to class later this week. Okay, but we'll say the hypothalamus is king, which controls the pituitary gland, and the pituitary gland has two lobes, and it's important that you keep the two lobes separate. So there's what we call an anterior lobe, that's this kind of pink area, and then there's the posterior lobe, which is this kind of tan area. The anterior pituitary is called the true endocrine portion of the pituitary gland. It's the actual gland part of the pituitary gland. And so sometimes we give it the name adenohypophysis. Adeno just refers to glands. So it's the part of the pituitary that's actually producing hormones. Okay, so it's the actual endocrine tissue. The posterior lobe of the pituitary gland we call the neurohypophysis, and that term neuro tells us that it's not really endocrine tissue like the anterior pituitary, but it's actually neural tissue, it's brain tissue. In fact, all that the posterior lobe of the pituitary really is axons that are coming down from the hypothalamus. There's actually no cell bodies there. Nothing is produced there. Nothing is really going on there from the pituitary. It's all just axons coming down from the hypothalamus. And the hypothalamus is going to produce some hormones, and it's going to dump them in the posterior lobe of the pituitary and then into the circulation. Okay, so the anterior pituitary is going to produce its own hormones, however, which then go out to control the rest of the glands in the body. And what connects the hypothalamus to the pituitary is this stalk that we call the infundibulum. And maybe you guys remember that already from the brain. All right, let's look at what these two tissues, the anterior and the posterior pituitary tissue, looks like under a microscope. It's not just some kind of artificial, sectioning off or demarcation that we've made up. It's actually different tissue, and you can see it. I mean, you can see that this tissue on this side looks different than this tissue on this side, right? This is the anterior pituitary, and this is the posterior pituitary. And you can see that the tissues are different. The anterior is full of cuboidal epithelial cells that are producing hormones and secreting them into the blood. The posterior is nothing but axons and supporting neuroglial cells. This is brain tissue, and this is endocrine tissue. We're going to see that the anterior lobe is going to produce and secrete numerous hormones. We'll look at 6 of them that you can see here, and we'll go through these again. The posterior lobe does not produce these 2 hormones, so don't be confused. There's no production of anything going on in the posterior pituitary. These 2 hormones, antidiuretic hormone called ADH or oxytocin, sometimes also called vasopressin. Those two hormones are actually produced up here in the hypothalamus, and then they are secreted down into the posterior lobe, and they meet up with some blood vessels there and go into the blood supply. Okay, so we talk about ADH and oxytocin being posterior lobe hormones, but I don't want you to think that that's where they're made. They're actually produced in the hypothalamus. They just get released in the posterior pituitary. All right, so let's start with the hypothalamus because he's the king. He's the supreme leader, right? So the hypothalamus is going to be the ultimate controller of the endocrine system. And he's going to have control in three ways. He's going to have three levels or three avenues of control. So first is through direct hormone release. And we talked about these already, oxytocin and antidiuretic hormone. So these two are made in the hypothalamus. They're actually hormones, and then they go to the body and control other organs. So that's one level of control, is by producing its own hormones that it releases through the posterior pituitary. Okay, the bigger way that it controls the endocrine system, however, is number 2 here. It's going to secrete hormones that go to the anterior pituitary, and then they tell the anterior pituitary to produce secondary hormones, and those secondary hormones will go to other glands like the pancreas and the thyroid gland and the adrenal gland, and will tell them to produce the hormones that kind of regulate body functions. And third, they can go directly from the hypothalamus. There are sympathetic nerves that go right to the adrenal gland, and we had talked about that briefly in the autonomic nervous system of the last section. So that's the third level of control, is direct neural control over the adrenal medulla through the sympathetic nervous system. And you're going to get release largely of epinephrine and a little bit of norepinephrine. All right, so hypothalamus is king, and then we come to the master gland, the pituitary gland, and we're going to talk about 6 hormones that are produced by the anterior lobe of the pituitary, what we also call the adenohypophysis. And these 6 hormones are thyroid stimulating hormone, and you're going to see that they each have like an acronym, because they're long words and we don't like to say them all the time. So we tend to use these acronyms all the time. So thyroid stimulating hormone is going to be TSH, and that's going to go to the thyroid gland and cause the secretion and release of thyroglobulin. And we'll talk about that process in physiology. Adrenocorticotropin hormone, which is a mouthful to say, so we just say ACTH, is going to go from the anterior lobe of the pituitary to the adrenal cortex of the adrenal gland, and it's going to cause the release of corticosteroids. And we'll talk about that more in a minute. Okay, the anterior lobe of the pituitary also produces and secretes growth hormone. And growth hormone is interesting. It doesn't go to just one particular gland like so many of these other hormones. It's going to actually go throughout the body and have kind of a general effect that leads to increased protein synthesis and cellular growth. Okay, prolactin is going to go to the breast and cause production of breast milk. Follicle stimulating hormone is going to go to the ovaries and to the testes, and have different effects there that we'll talk about in physiology. We'll probably mention it briefly in our last lecture of anatomy, but we'll talk more about how FSH affects ovaries and testes. But they're going to help promote the development of the male and female sex cells, and then they're going to cause the release of estrogen from ovaries. Okay, and the last hormone from the anterior pituitary is luteinizing hormone, and these two go together. You can think of FSH and LH together because they're secreted always together, and both of them are going to the male and female sex organs, the ovaries and testes, and they're having effects at those organs. And so luteinizing hormone is going to cause ovulation. It's going to promote progesterone secretion in women and testosterone secretion in men. So you see there's 6 hormones to the anterior lobe of the pituitary gland, and a lot of these are going to other glands and telling those other glands to produce more hormones. All right, so this is just kind of showing you in picture form what we just talked about. So those of you who like pictures can kind of try to learn it here from this picture. So I mentioned that we have kind of a hierarchy, right? We have the hypothalamus is telling the pituitary what to do, and the pituitary is telling other glands which hormones they should produce and release, right? So you see we've got kind of a hierarchy, or this is what we would call the axis, the hypothalamic pituitary axis. And so let's start kind of following this axis and seeing how the release of certain hormones from the hypothalamus trigger the pituitary to secrete certain hormones, which then trigger glands to secrete further hormones. So let's say we need the release of thyroid hormone, okay? So our thyroid hormone levels are low, and the body tells the brain, hey, we're low on thyroid, we need to produce more thyroid gland. The very first thing that's going to happen is the hypothalamus is going to send a signal, right? Hypothalamus is the king, so everything starts with him. So in this example, if we needed more thyroid gland, the hypothalamus would secrete thyrotropin releasing hormone, and that would travel to the pituitary, so TRH would travel to the pituitary, and the pituitary would then produce something called TSH, thyroid stimulating hormone, and thyroid stimulating hormone would go to the thyroid gland, and the thyroid gland would produce thyroid hormone. And then we would increase the amount of thyroid hormone in the blood. So that's kind of what we mean by an axis, that one thing leads to the release of another, which leads to release of another, which eventually leads to what we actually need, which in this case is thyroid hormone. Okay, so right now this slide is really introducing you to what we call the releasing hormones. This is step one in this axis. And step one is from the hypothalamus. So the hypothalamus has a few of these releasing hormones. And notice that their names all have releasing in the name for the most part. So thyrotropin releasing hormone, right? That's TRH. Corticotropin releasing hormone, CRH. Growth hormone releasing hormone, which is growth hormone, RH releasing hormone, is going to stimulate the secretion of growth hormone from the pituitary. And gonadotropin releasing hormone is going to lead the pituitary to produce LH and FSH. So all of these releasing hormones come from the hypothalamus. So if you see a test question, for example, and it has the word releasing in it, it has something releasing hormone, you know that that one had to come from the hypothalamus. All of the ones that come from the hypothalamus have that term releasing, at least all the ones that I'm showing you here. If it says stimulating, well, that may be from the thyroid or somewhere else. But if it says releasing hormone, that's going to be from the hypothalamus. Okay, so that's kind of the king, that's kind of the starting point. From the hypothalamus, those releasing hormones will go to different places. But we still have to talk about those two hormones that don't go to the anterior pituitary, but rather go from the hypothalamus to the posterior pituitary, right? So there are two hormones produced, ADH, which stands for antidiuretic hormone, and oxytocin. Those are produced in the hypothalamus and go to the posterior pituitary. And then they're going to have their effects on their target organs from there once they get released into the blood. So ADH is going to promote water reabsorption. It's antidiuretic hormone, so diuresis or diuretic means to make a lot of urine. So antidiuresis, antidiuretic means to prevent you from making a lot of urine. That means you're going to reabsorb that water instead of releasing that water in urine. So that's going to be really important at maintaining your water balance and even your blood pressure. We'll see when we get to physiology. Oxytocin has two primary functions. I mean, there are a lot of functions of oxytocin, but the two primary ones are uterine contractions during labor for a woman, and then the ejection of breast milk during breastfeeding. So the production of breast milk is going to occur through a different hormone called prolactin, but the ejection of that milk as the baby sucks, in order to get the milk out of the breast and out through the nipple and into the mouth of the baby so the baby can drink it, you have to have oxytocin. All right, this is what we will go over in class together when we meet later this week. We will talk about how each of these releasing hormones or other hormones from the hypothalamus affects the pituitary, anterior, posterior, what it causes to be released from the pituitary, and then where those hormones then go and what they cause to be released from their target organs as well. So this is a really nice overview for you of the hormones of the hypothalamus, which hormones of the pituitary they trigger, and where those hormones from the pituitary then go, what target organs they reach. And again, we'll talk more about this in class together. All right, so let's start a discussion of individual hormones by talking about a case of Mary. So Mary is 45 years old, and she comes to see you in the clinic because she's having some trouble losing weight. She currently weighs about 230 pounds. She's tried 2 diets in the last 6 months, but says she continues to slowly gain weight, even though she doesn't feel like she's eating very much. She also complains of being tired all the time, even though she says she sleeps well. In fact, she says she sleeps 8 to 10 hours a day and gets good sleep, but still feels tired during the day. She says she seems to be cold and other people feel warm, and she also notes some constipation for the last 6 months. So we're going to go through some of the endocrine organs now, or glands, and see if we can figure out what is wrong with Mary. All right, so let's start by talking about the thyroid gland, and we'll look at the gross anatomy of the thyroid gland first, what you would see if you just kind of remove the skin from the anterior neck and we're able to kind of tease down and look at the thyroid gland. This is what it would look like. We used to say back in my day that it looks like a butterfly, that it's kind of a butterfly-shaped organ. I think it kind of looks more like a Xbox controller, if you ask me. And so either way, whether you think of it as a butterfly or an Xbox controller, you can kind of get an idea of the shape. There's kind of 2 lobes, a right and left lobe, and then there's what we call the isthmus, which is the part in between the right and left lobe holding it together. And it is fed by superior and inferior thyroid arteries, which are both branches of the carotid arteries, and it sits right anterior, right on top of the trachea, and just below the thyroid and cricoid cartilages. So the thyroid cartilage, if you remember, is what we called the Adam's apple, and the next cartilage down from that was the cricoid cartilage, and then so just below those 2 is where you would find the thyroid. And you'll get a chance to actually dissect the pig and get down and see if you can locate the thyroid gland, and you should be able to quite easily. When we want to feel someone's thyroid, on an exam, we put our finger over the Adam's apple. That's kind of our first landmark. And then we move our fingers down about 1 finger breadth below the Adam's apple, and you should be over the area of the thyroid. Now, in a healthy person that has a healthy thyroid, it's very difficult to feel. It's so small and thin and soft that it's very difficult to feel. If you have the patient swallow when you have your finger on their neck just below the Adam's apple, you should be able to feel the isthmus of the thyroid kind of rub against your finger as you swallow and your throat moves up and down. Now we can look at the histology of the thyroid gland, kind of go microscopic and say, what would it look like if we took a slice of thyroid tissue and looked under the microscope? This is what it would look like. It's composed of numerous thyroid follicles. Think of follicles as like little sacs full of fluid and surrounded by epithelial tissue, cuboidal epithelial cells that are producing the precursors of thyroid hormone. So the follicles are lined with that epithelia, and that's making thyroglobulin. And thyroglobulin, because it starts with a T, we call those these epithelial cells, we call them T thyrocytes. And we call the fluid inside that has thyroglobulin plus some other fluids in there, we call that colloid. And colloid is really just another name for proteins. And since hormones are proteins, that's really a fairly good name for what's inside. There are also what we call C thyrocytes, and they are responsible for making something called calcitonin, which is helpful in calcium regulation. Okay, so the T thyrocytes we mentioned, they produce thyroglobulin and secrete it into the colloid, this is the colloid here, and these are the T thyrocytes surrounding it. Iodine is then added to the thyroglobulin that's produced by the T thyrocytes, and that addition of iodine to the thyroglobulin turns it into thyroid hormone. And we'll, again, talk more about that in physiology. Then we have, as I mentioned, the C thyrocytes. These are other cells mixed in there. They do not surround the colloid. They're just kind of randomly scattered throughout the thyroid, and they're going to produce calcitonin. That's where the C and C thyrocyte comes from. Remember, cyte just means cell, right? So thyrocyte is a thyroid cell, and a C thyrocyte produces something that starts with a C, that's calcitonin. And calcitonin, you can see the word calcium is almost in that word. So that should help you remember that calcitonin is used in calcium regulation, and calcium, of course, is needed for bone growth. Whereas T thyrocytes produce thyroglobulin, which also begins with the letter T. All right, so let's just kind of review how this axis works, right? From the hypothalamus to the pituitary to the gland. And in this case, we're talking about the thyroid. So let's say it starts by having a reduced level of thyroid hormone, what we call T3 and T4. So that's going to be sensed in the hypothalamus. Hypothalamus is going to say, oh, we've got a low level of thyroid hormone. We need to make more. So it's going to release thyrotropin releasing hormone. And that thyrotropin releasing hormone is going to go to the anterior lobe of the pituitary gland. It's going to stimulate the anterior lobe of the pituitary to secrete thyroid stimulating hormone. And thyroid stimulating hormone is going to go into the blood. It's going to go everywhere in the body, but only the thyroid gland has receptors for TSH. So when the TSH reaches the thyroid gland, it's going to stimulate the thyroid gland to produce and then release more T3 and T4, which is thyroid hormone. That's going to lead to an increase in T3 and T4, which, by the way, will feed back to the hypothalamus and say, hey, we've got enough thyroid hormone now. You can stop producing TRH. When you shut off TRH production, it's going to shut off TSH production. And when you shut off TSH production, it's going to shut off T3 and T4 production. So that's kind of how you get one stimulus kind of affecting another, specifically for the thyroid gland. So, and this is our patient's problem. So our patient had symptoms of weight gain, fatigue, constipation, feeling cold. All of these are symptoms of a low thyroid hormone level. So the T3 and the T4 would be low. So that would cause, for example, it should cause the release of TRH. TRH should be elevated, right? Which should then go and cause TSH to be elevated, which should then go to the thyroid and make T3 and T4 normal again. But there's a problem with the gland, where the gland either is not producing thyroid or it's no longer responding to TSH. It's got some kind of inflammation that is causing it to not respond to TSH. So if you check this person's blood, you would find an increase in TRH, an increase in TSH, and a low level of T3 and T4. That would tell you the problem is here at the thyroid gland. Okay, parathyroid. Para just means next to. So parathyroid means glands that are next to the thyroid. They actually have nothing to do with the thyroid gland. They have a completely different function. They get their name simply from their anatomical location of being next to the thyroid glands. In fact, they're not next to the thyroid gland, they're right behind. So this is a posterior view of the thyroid. So you'd be looking from the back of somebody's neck, and you'd have to remove their trachea and everything else, and then you could see the thyroid gland from a posterior view, and you would find 4 tiny parathyroid glands kind of embedded in the posterior thyroid, 2 on each side. And these are very difficult to find in real life. They just look like little globules of fat. They look like a lot of the other fat tissue that's surrounding your organs. And so, for example, when surgeons have to take out your thyroid or half of your thyroid because of maybe a thyroid cancer, they try to find these parathyroid glands and they try to isolate them and so that they don't remove them with the thyroid gland. But every now and then they're very difficult to find, and you end up losing your parathyroid gland when you remove the thyroid gland. So they're kind of stuck to the backside of the thyroid. And there's 4 of them. They produce parathyroid hormone, should be easy to remember, parathyroid gland, parathyroid hormone. And these are involved in calcium regulation. And again, we'll talk a bit more about that in physiology, but for now, just know that a low level of calcium causes PTH levels to rise, and when PTH levels rise, that causes the release of calcium from bones, as well as some effects on reduced kidney excretion, and it all ends up increasing the blood levels of calcium. So it's involved with calcium regulation. The thymus gland is a gland that is much more important early in life. It's quite large proportionately in a child. It reaches its largest size during adolescence, and then it begins to kind of shrivel, and by adult size, it's typically quite small and not very active. So it's active more early in life, producing immune cells and helping with immune function, and we'll talk about that a little bit when we get to immunology in physiology. It sits in the mediastinum. So there's the thyroid, and if you go inferior to the thyroid down into the mediastinum, between the lungs and superior to the heart, you'll find the thymus gland. If you just took it out, it looks not too different from the thyroid, really. But it's bigger, typically, especially in a younger person, than the thyroid gland, and is located in the mediastinum. All right, adrenal glands. These are 2 tiny, tiny glands that sit on top of each of your kidneys. So you have 1 on top of each of your kidneys. And there are 2 major sections to the adrenal gland. There's the adrenal cortex. That's this outside, what looks kind of white on the picture. And then there's the adrenal medulla, which is this purple-looking stuff on the picture. And we've already talked about the adrenal medulla and how that responds to sympathetic stimulation and releases epinephrine primarily into the blood supply. The adrenal cortex is much more complex. It releases several different types of hormones and is involved in kind of a water balance of the body as well as electrolyte balance in the body. So if you looked under the microscope and you looked at just the cortex, you can see that there's different layers. There's a capsule surrounding it. There's a zona glomerulosa, a zona fasciculata, a zona reticularis. We're not going to go into the function of those very much in physiology. If we have time, we will. I just wanted to mention those names because different hormones are produced in different layers. So this layer of the adrenal cortex not only looks different under the microscope, but it looks different because it functions different. It's making a different type of hormone. The zona fasciculata is making its own type of hormones, and the zona reticularis is making its own types of hormones. And then the adrenal medulla has chromaffin cells and is producing and releasing epinephrine and norepinephrine. Mostly epinephrine, you can see there. Okay, so let's discuss another case. This is the case of Mohammad. He's 8 years old and has been losing weight for the past 3 months. He's very tired. His parents tell you that he urinates a lot. He's constantly thirsty, and they only brought him to you today because this morning he became lethargic, and they thought he was breathing kind of funny, and so they brought him to the hospital. So 8-year-old losing weight, tired, drinking a lot, urinating a lot, and is now lethargic. What is the potential diagnosis? Now, you know we're talking about some kind of endocrine disorder, so let's talk about the pancreas. The pancreas anatomically is posterior to the to the stomach, the organ called the stomach. And it's actually what we call retroperitoneal. The peritoneum is your abdomen, basically. And most of the organs that you think of as being in your abdomen, they are within the peritoneum or the peritoneal cavity. So, for example, your stomach and most of your intestines and your liver and your spleen and all those organs in there, they're in your abdomen, they are in the peritoneal cavity. However, there are a few organs that you probably aren't aware of that actually are behind the peritoneum, behind that sac that holds most of your abdominal organs. There's actually another layer that's posterior to all of that. That's called the retroperitoneal space. And we'll talk about that a little bit more in the gastrointestinal system. And when you dissect your pigs, you'll get to actually experience that. But needless to say, it's very deep. Okay, it's a very deep organ. It's behind the stomach, but it's even behind the peritoneum. It's retroperitoneal. It's very deep. It has three main parts. It has what we call a head. It's kind of this circular part here. And then it has the tail. And then the rest of it would be considered the body. So there's three sections to it. And there are two major other anatomical structures that you have to know inside. One would be the pancreatic duct. You can see it running right there through the middle. And that pancreatic duct empties into a hole in the intestine that has a sphincter muscle, a circular muscle, that kind of controls the opening and closing of that hole, so that all of the exocrine enzymes and fluids that are made by the pancreas can be drained through that pancreatic duct and can come out that hole, which is called the sphincter of Oddi. And the sphincter of Oddi is shared by the common bile duct of the gallbladder. So they both empty into that hole. The hole is actually called the ampulla of Vater, but you don't have to learn that. And if a stone, let's say you have a gallstone from your gallbladder, and that gallstone leaves the gallbladder and gets down into the common bile duct and gets stuck right at that ampulla of Vater, then the pancreatic juices that are trying to leave the pancreas, they can't leave and go into the intestine because they share an opening, they share an exit, and that exit is now blocked with the gallstone. So that exocrine fluid, which is bicarbonate and a lot of digestive enzymes, backs up and actually begins to digest the pancreas itself, and you get something called pancreatitis. So it's important to recognize where the duct empties and that it shares an exit with the bile. So the pancreas has two functions. It has exocrine function. Exocrine means it's produced by a gland and secreted somehow to the outside of the body. So for example, your salivary glands would be considered exocrine. They produce saliva and it gets put into your mouth, which eventually leads to the outside of the body. Here, 99% of the pancreas is exocrine, producing bicarbonate, H2CO3, and digestive enzymes. And those are going to go into the intestine, which is another way of basically going to the external environment, right? Eventually your intestines open up through the rectum and out the anus into the outside world. Only 1% of the pancreas is actually endocrine, which is what we're talking about right now. When we get to the digestive system, we'll talk about the exocrine function of the pancreas. But for this lecture, we're going to talk about that 1%, which is the endocrine function. So the endocrine function, that 1%, that occurs in what we call islets of Langerhans, or pancreatic islets. So if you were to take a slice of pancreatic tissue and look under the microscope, you would see a sea of exocrine tissue. And every now and then you'd see a little island, an islet of Langerhans, and that would be a small part of the pancreas that's producing some kind of hormone. And different hormones are produced in the pancreas. We're only going to talk about two of them. Alpha cells in these islet of Langerhans, they're going to produce glucagon, which causes the release of glucose from stored glycogen. So glycogen is basically a carbohydrate that's used to store glucose in your body. So if you take in too much glucose, a lot of it gets stored as fat, but some of it gets stored as glycogen. And then later, when your glucose levels are low and you need some glucose, glucagon will be released, and it will cause the breakdown of that glycogen back into glucose, and that glucose will be released into your blood for energy. Okay, the other one that most of you are probably familiar of or have heard is insulin, and insulin is made from beta cells. So glucagon from alpha and insulin from beta. Make sure you can distinguish those two. Insulin is used to actually remove glucose from the blood and to present it to your tissue. So let's say you're exercising and you need ATP in your muscle. You need energy for contraction of your muscle. You're going to get that energy by breaking down glucose. The problem is the glucose is in the blood, and you need the glucose to get from the blood into the muscle. The way that it gets from the blood into the muscle has to do with insulin. Insulin is involved with kind of opening the door for glucose to enter tissues, and not just muscle tissue, but all kinds of tissues in your body. And so without insulin, the glucose stays in your blood and never gets to your tissues, and your tissues actually starve. Even though you've got tons of glucose floating around, it can't get into the tissues that need it to use it for energy, and your tissues feel like they're starving. So insulin is super important, and in fact, we would all die without it. So that leads us to this discussion of diabetes and coming back to the story of Mohammad. So Mohammad is losing weight, right? He's tired all the time. He's urinating a lot. He's drinking a lot. So let's think about what I just mentioned about the function of insulin. So if you had a lack of insulin or a low insulin, you would not be able to use the glucose that was in your blood, right? So your tissues would feel like they were starving, and they would actually start to use up fat stores, because fat can be turned into energy, and protein can be turned into energy, and neither of those require insulin. But in order to use glucose, which is the preferred source of energy, you have to have insulin. So let's say you have type 1 diabetes. That's what we call juvenile. It usually starts when you're a child. And that occurs from a loss of beta cells, a loss of insulin-producing cells in the islets of Langerhans in your pancreas. So you're not making insulin. That means you cannot get the sugar out of your blood and into the tissues that need it. Well, your tissues are going to find another source of energy, and they're going to find that source through fat and protein. So they're going to start breaking down any fat stores that you have, and when those are used up, they're going to start breaking down your protein. And protein is basically your muscle, and it's going to start breaking down your muscle and using those amino acids for energy. So you're going to lose weight. You're going to start to waste away. And you're going to be tired all the time, because that's not an efficient way to make energy. So you never have enough energy. You feel tired all the time. So here we have Mohammad, losing weight, tired all the time. What about his drinking a lot and urinating a lot? Well, remember, the blood now is full of glucose. And that blood is going to go to the kidneys just like it goes everywhere else. And as your blood gets filtered through the kidneys, that glucose is going to spill over into the kidney tubules, and it's going to bring with it a bunch of water that's going to follow all that glucose, and you're going to make a ton of urine, which means you're going to be peeing all the time. And because you're peeing all the time and getting rid of all that fluid, you're going to be low on your total body fluid, which means you're going to be thirsty and drinking all the time. So that explains why he's losing weight, he's tired, he's drinking all the time, and he's urinating a lot. Poor Mohammad has type 1 diabetes. The only way to treat that is by giving insulin. You can't take pills for that. You've got to take insulin. Okay, type 2 diabetes is much more common, especially in the Western world. In places where obesity and sedentary lifestyle are becoming more of the norm. This occurs from insulin insensitivity. So it's not that you're not making insulin. In fact, when most people with type 2 diabetes are diagnosed, they actually have higher than normal levels of insulin. Because the problem isn't that you don't have it, the problem is that it's not working properly. Insulin's job, is to take the glucose and present it to your tissues, right? And to help open the door so that the glucose can enter your muscle and your other tissues. Well, when insulin isn't working right because you have too much adipose tissue and that has changed the biochemistry of your blood. And now the tissues become insensitive to insulin. That means that some of the glucose maybe gets to your tissues, but a lot of it gets stuck out in the blood. And so that one usually begins later. Now this is classically, it had begun in later adulthood, 40, 50, 60 years old. Unfortunately, because we have a childhood obesity epidemic in America, we now have a childhood type 2 diabetic epidemic also in America. Type 2 diabetes follows obesity and a sedentary lifestyle. And because so many of our children are becoming obese and living sedentary lifestyles, playing video games instead of going out and running around, we have way more children. If you had asked me 20 years ago, I would say if a child has diabetes, it's type 1. Now, it depends. If the child is obese, it's probably type 2 diabetes. If the child is thin, it's probably type 1 diabetes. This one you can treat with pills, and that's most commonly what you see people on. I will say eventually, even patients with type 2 diabetes will go on to need insulin later on in their disease. All right, lastly, the reproductive system also produces some hormones. The main one that I want you to know is testosterone for the testes, and then there's 2 in the ovaries, estrogens and progesterone. So testosterone, and we'll talk about these more when we actually get to the reproductive system, but testosterone helps with sperm production and maturation. It's what makes men look like men. It's what makes us grow hair. It's what makes us grow more muscle than the average woman. It's what makes our voice become low. It's what gives teenagers acne as well. So testosterone is pretty much the hormone that makes men more like men. Don't worry about inhibin. Estrogens in women, that's kind of what makes a woman more like a woman. So for example, if I want to know if a young woman is going through puberty, breast development will tell me whether or not she's hit puberty. Once you hit puberty, estrogen production increases, and estrogen is what causes breasts to develop in women. So again, it's kind of what makes externally, it's what makes women look more like women externally. It also helps to promote ovulation and helps to regulate the menstrual cycle. And then we talked about FSH and LH involved there, and we'll talk about that a little bit more in physiology. Part of the ovary during menstruation, after the egg is released, something called a corpus luteum is made, and that produces progesterone, which helps support a baby embryo if the woman happens to be pregnant. So I would remember testosterone for men and what it does, estrogen and progesterone for women and what they do.